Right, right. So it's the internal critical thinker versus an external critical thinker
Yeah. Right.
to,
Yes.
to help
Yeah.
strategize. So,
Yeah.
you kind of reminded me of the what a lot of people use yellow flags like anxiety, this fear avoidance or pain avoidance kind of behavior, and just to kind of go through the red flags we want to avoid, we want to rule out those, make sure there's nothing emergent, truly emergent.
Yep.
And then the yellow flags are things that can interfere with your progress or self-resolution based on how you're avoiding, movements that you really maybe should do. And then I like to call it white flags when there's like, it's almost like a surrender. Like there's actually a mechanically reversible condition, which I think most physicians aren't trained in. And
Yeah.
I feel like the white flags are where we're missing a big chunk of patients because we're not recognizing that we don't
Right.
need to just treat the symptoms. There might be something actually mechanically reversible.
Yeah, that's right. I think you're right. That is a something that lacks in many arenas in terms of education,
Mm-hmm.
and I think. Um, for example, the inflammatory cause of pain. Obviously, pain is some pain is stimulated or caused by inflammatory kind of mediators. But I think the proportion compared to those musculoskeletal problems that are caused by a mechanical problem, the mechanical problem far outweighs that, and I think that's way under recognized.
Mm-hmm.
And yes, so uh, um, I must say that for most physicians and family doctors, for example, they have a very short amount. Obviously, they have a very short amount of time with patients,
Mm-hmm.
and to try and get a handle on that, the nature of the pain is really challenging. I mean,
Mm-hmm.
we're doing assessments in sort of the minimum of half an hour. Ideally, that's sort of 40 minutes and sometimes more, and you're moving the patients around a lot and you're monitoring the response. But I think just that knowledge that them trying to get as people trying to get clues from the history, from the conversation with patients in terms of, okay, what could be, what's the most likely sort of nature of this problem, and does it sound mechanical, is it intermittent, is it influenced by different positions and movements, and could the patient potentially find strategies to get themselves out of this, or have they got sort of constant unrelenting pain, they've just fallen down the stairs and they're still recovering from that, or as you mentioned, are there some serious barriers to recovery here, and psychosocial issues that maybe these are going to need to be addressed before we get any degree of recovery here.